Hello, everyone. Today I will be talking about diuretic agents. By the end of this lesson, you should be able to explain how the kidneys and nephrons regulate fluid, electrolytes, and blood pressure. Identify where each class of diuretics work within the nephron. You'll compare loop, thiazide, potassium-sparing, carbonic anhydrase inhibitors, and osmotic diuretics, including their mechanism of action, therapeutic uses, prototype medications, adverse effects, contraindications, and drug interactions. Finally, you'll be able to apply the nursing assessment, interpret lab values, provide patient education, and use clinical judgment to safely administer diuretics to evaluate patient outcomes. Know where the drugs work in the nephrons, understand how it changes fluid and electrolytes, and you'll know its uses, side effects, and nursing priorities. Diuretics are medications that help the kidneys remove extra sodium and water from the body. Although they increase urine output, their most important effect is getting rid of sodium. Normally, the renal tubules reabsorb or take back the sodium into the bloodstream. Diuretics block this reabsorption, so sodium stays in the urine. Since water follows sodium, more water is also excreted. The result is less fluid in the blood vessels, which lowers blood pressure and reduces edema, making diuretics useful for conditions like high blood pressure, heart failure, and fluid overload. Where sodium goes, water follows. So diuretics usually block sodium reabsorption. Sodium and water leave in the urine, so therefore there'll be decreased blood volume, decreased blood pressure, and edema. Edema is associated with heart failure. Not enough blood is sent to the kidneys, causing an activation of the RAS. Acute pulmonary edema due to left-sided heart failure. Lung capillary permeability, which causes decrease in gas exchange. Liver disease, which includes cirrhosis. Renal disease, like chronic kidney disease. Hypertension, decreased fluid pressure in the eye, intraocular pressure. It's useful for treating glaucoma. Conditions that cause hyperkalemia. Goal is to decrease potassium in some diuretics, except for potassium sparing, and the goal is to decrease volume and sodium. With diuretics, this medication helps the kidneys remove extra sodium. Although they all increase urine output, each class works at a different part of the nephron, has different strength, and has a unique side effect and nursing considerations. We'll cover thiazide diuretics, loop diuretics, carbonic anhydrase inhibitors, potassium-sparing diuretics, and osmotic diuretics. So by the end of this lesson, you'll know where each works, how it works, the major adverse effects, and their key nursing points. Remember, same goal, remove excess fluid, different location. As you see, this is where the nephron is. Osmotic starts here. Proximal tubule, then carbonic anhydrase inhibitors are here. Loop of Henle, that's why loop diuretics get their name. Loop diuretics absorb here. Spironolactone is after all the sodium is reabsorbed. You'll see it after here. I'll talk to you a little bit more about it so you can understand it better. In this diagram, it shows where the different classes of diuretics work inside the nephron. The kidneys function. Carbonic anhydrase inhibitors work early in the proximal tubule, right here. Loop diuretics act in the ascending and are the most powerful, removing large amounts of sodium and water. Thiazide diuretics, right here, work in the distal convoluted tubule, causing moderate fluid loss and are commonly used in hypertensive. Potassium sparing, which is spironolactone, work in the collecting duct, helping remove sodium in water while preventing potassium loss. Osmotic diuretics, which is here, work mainly in the glomerulus and loop, pulling water into the urine by osmosis. Loop, lots of fluid. Thiazide treats hypertension. Spironolactone saves potassium. Carbonic anhydrase inhibitor is in the proximal tubule. Osmotic pulls water into the urine. When it comes to diuretics, children do take them. So in children, diuretics are used carefully because they are more sensitive to fluid and electrolyte changes, so they require close monitoring. In adults, the focus is on taking the medication consistently, monitoring daily weights. You check the weights every day at the same time, same clothes, same scale. Make sure your patients stay hydrated. And you watch for any electrolyte levels, especially potassium. In older adults, kidney function naturally declines, making them more susceptible to dehydration, low blood pressure, falls, and electrolyte imbalance. Across all age groups, nurses must monitor fluid balance, electrolytes, blood pressure, kidney function, and signs of dehydration to keep the patient safe. Diuretics are not routinely used during pregnancy because they actually reduce blood volume, which may decrease blood flow to the placenta and affect fetal growth. However, they may be prescribed when a pregnant patient has conditions such as heart failure, pulmonary edema, or chronic hypertension. And the benefits outweigh the risks. Nurses should monitor the mother's blood pressure, fluid status, electrolytes, kidney function, and fetal well-being throughout the treatment. Why do we use diuretics? It's to treat edema, heart defects, renal lung disorders, controlled hypertension, especially for children. So the safe, commonly used drugs are thiazides, like hydrochlorothiazide or chlorothiazide, loop, which are another name is furosemide. The max for children is 6 milligrams per kg per day. So yes, you'll be doing drug calculations when it comes to children. Potassium sparing, spironolactone, avoid if the patient has severe renal impairment. So this is why it's important to look at the BUN and creatinine. Avoid ethacrynic acid in infants. So, nurses, what do you think your priorities will be? Monitor electrolytes like sodium and potassium. Assess for ototoxicity, which is mainly with furosemide. So, ringing in the ears, and they might end up losing their hearing if you don't pay attention properly. Watch for rapid weight gain or loss, because that's the problem with the fluid balance. Evaluate urine output and hydration. Effects happen quickly due to faster metabolisms in children, so you have to watch them closely. When it comes to adults, why do we give adults diuretics? Again, for hypertension, heart failure, chronic edema. Nurses, our responsibility, again, weigh daily. Same time, same scale, same clothing. Report sudden weight changes if it's more or less than 3 pounds a day, 5 pound weight gain in a week. Avoid dehydration, like vomiting, diarrhea, sweating. You have to make sure you watch your patients for that. Or if they're being discharged, to educate them that on that as well. Maintain adequate fluid intake to prevent fluid rebound. Potassium considerations. Potassium wasting diuretics like furosemide and thiazides encourage potassium-rich foods. Periodically check their potassium. Some may need supplements. Potassium-sparing diuretics like spironolactone avoid high potassium foods and supplements and the salts. So for special populations, pregnancy, avoid unless medically necessary, may affect the fetus. And with breastfeeding, diuretics may affect supply. It may decrease the milk supply. So find an alternate way of feeding if the benefits outweigh the risk. Older adults are common concern is more likely to have renal or liver impairments because as you get older, it diminishes. So that increases their risk for toxicity. They also have a higher chance of adverse effects from dehydration and electrolyte imbalances. Frequent monitoring of electrolytes is our function for nurses. Watch for orthostatic hypotension. Assess hydration status carefully, like their skin turgor. You're not going to touch their hand for skin turgor. What is the location that you would check for skin turgor? I'm not going to tell you because you learned this in health assessment. Consider diet. High salt diets worsen the edema. Encourage healthy sodium fluid intake to prevent fluid rebound. Special note, activity levels affect diuretic needs. So monitor for changes in patient activity levels. So if the patient says they started working out now, they're going to increase more fluid output. So they will be at risk for hypotension, orthostatic hypotension. So education is key. Thiazide and thiazide-like diuretics, their therapeutic actions, they block the chloride pump. The sodium passively moves with chloride. So it keeps chloride and sodium in the tubules to be excreted in the urine. It prevents reabsorption of both sodium and chloride in the vascular system. They are the first line drugs to manage essential hypertension when drug therapy is needed. Other indications vary by specific drugs. They're well absorbed from the GI tract. They are metabolized in the liver and excreted in the urine. They cross the placenta and enter human milk. Contraindications, as usual, if they're allergic, you don't give it. If they have hypovolemia, we're not going to give it to them because diuretics can worsen that condition. If they have severe renal disease, causes like azotemia. Azotemia means that they do not have enough urine. I'm sorry, increased BUN and elevated creatinine. You must notify the provider and stop medication. Thiazide diuretics should be used with caution in certain patient populations because they can increase blood glucose. They may worsen diabetes or glucose intolerance. They also increase uric acid levels, which can trigger gout attacks. Patients with liver disease and are higher risk for electrolyte imbalances, and those with systemic lupus erythematosus, SLE, may experience worsening kidney involvement. Thiazides can also increase calcium levels, so use caution in patients with hyperparathyroidism. And they may increase lithium levels, requiring careful monitoring in patients with bipolar disease. They should also be cautiously used during pregnancy and breastfeeding. Remember, in pregnancy is not advised, but if the benefits outweigh the risks, you give it. So remember, diabetes, it may increase the blood glucose. If the patient has a history of gout, it may increase the uric acid and trigger attacks. Patient has a bipolar disorder and is on thiazide, it can increase lithium toxicity. Hyperparathyroidism may increase calcium levels, so monitor that. If the patient has liver disease and SLE, they have higher risk for complications. Pregnancy, lactation, only if benefits outweigh the risk. Monitor blood glucose, uric acid, calcium electrolytes, kidney functions, and blood pressure. So remember, thiazides can raise three things: sugar, uric acid, and calcium. Thiazide diuretics are generally well tolerated, but nurses should monitor several important adverse effects. The most common are GI upset, hypokalemia, dehydration, and hypotension. Unlike loop diuretics, thiazide decrease calcium excretion, so calcium stays in the bloodstream, which can lead to hypercalcemia. They also increase uric acid, which may trigger gout. Remember, watch. Most important, electrolyte imbalance problems like hypokalemia could cause muscle weakness, cramps, and dysrhythmias. Hypertension, remember, is from the dehydration. Increased calcium is called hypercalcemia, and a patient with elevated parathyroid levels could cause increase in calcium levels. Increased uric acid, gout flare-ups, Long-term therapy may cause blood glucose to elevate, hyperglycemia. Again and again, monitor potassium, sodium, calcium, glucose, uric acid, kidney function. Check the blood pressure because the patients will have orthostatic hypotension. How will you educate them? Thiazide diuretics interact with several commonly prescribed medications. Because they can cause hypokalemia, the increased risk of digoxin toxicity, potassium levels need to be monitored closely. They can also increase the risk of arrhythmias in patients taking quinidine. Since thiazides may raise blood glucose, they can reduce the effectiveness of anti-diabetic medication. So if your patient is diabetic and they're on thiazides and you're monitoring their sugars inpatient and the patient's like, I didn't eat that much, consider it's because of the diuretics. Have a conversation with the doctors to see what we could do to either change the type of medication or to closely monitor your patient. You don't automatically stop, you consult. Intercollaboration. Remember, patients also have the risk of increasing their lithium levels and causing the risk for lithium toxicity in bipolar patients. Finally, when combined with other antihypertensive medications, what do you think could happen with the blood pressure? You got it, excessive hypotension. So patients should be taught to rise slowly and report dizziness. So the digoxin and thiazide increase the risk for the digoxin toxicity. Why? Because hypokalemia makes the digoxin more toxic. Quinidine and hypokalemia increase the risk for dysrhythmias. Anti-diabetic medications, thiazides may increase blood glucose, reducing diabetic medication effectiveness. Lithium thiazide increase lithium levels, increase the risk for lithium toxicity. Other antihypertensive medications increase the risk for orthostatic hypotension and falls. So HCTZ or hydrochlorothiazide is our prototype for thiazide diuretics. It works in the distal convoluted tubule where it blocks the reabsorption of sodium and chloride. So that means it's going to be pulled into the urine. So whatever's in the urine will pull more water. As sodium stays in the urine, water follows. It increases the urine output and it lowers the blood pressure. HCTZ is commonly used as a first-line treatment for hypertension and is also used to treat mild edema from heart failure, liver disease, and kidney disease. Nurses should monitor for hypokalemia, dehydration, orthostatic hypotension, and electrolyte imbalances. Teach your patients to take it in the morning to prevent nighttime urination. So here's a question. What do thiazide diuretics block? Chloride pump, sodium pump, potassium pump, carbonic pump. Chloride pump. Thiazide and thiazide-like diuretics act to block the chloride pump. Chloride is actively pumped out of the tubule by the cells lining the ascending limb of the loop of Henle and the distal tubule. So sodium passively moves with the chloride to maintain electrical neutrality. Loop diuretics, as you know, the name comes from the loop of Henle. So it actually works here, where more fluid is, where sodium is supposed to be reabsorbed, and you're not going to get that. So it blocks the chloride pump as well in the ascending loop of Henle. Therefore, it decreases the reabsorption of sodium and chloride. It's the drug of choice when rapid and extensive diuresis is needed. In other words, if you want to get that urine out really fast, this is one of the medications that we're going to use. As usual, we have this as an IV pump. I'm sorry, IV push, or we give this PO, which means by mouth. It's given for acute heart failure, acute pulmonary edema, edema associated with heart failure, or with renal or liver disease and hypertension. Loop diuretics, such as furosemide, which is our prototype drug, are rapidly absorbed, but how they are metabolized and eliminated depends on the specific drug. Before giving a loop diuretic, nurses should check for important contraindications. These drugs should be cautiously or avoided in patients with severe electrolyte depletion, anuria, meaning that they're not urinating, severe liver disease with hepatic encephalopathy, pregnancy, or drug allergies. Because loop diuretics cause significant fluid and electrolyte loss, patients require close monitoring. Okay, so they have the risk for dysrhythmias, muscle cramps, weakness, and seizures. Anuria means no urine production. If the kidneys are not making urine, the medication has nothing to work on. Giving the drug will not be effective and may increase adverse effects. Patients with severe liver disease are already at risk for confusion due to high ammonia levels. Loop diuretics can cause hypokalemia and metabolic alkalosis, which increases ammonia production. This can worsen hepatic encephalopathy, leading to increased confusion, lethargy, or coma. When it comes to pregnancy, loop diuretics reduce maternal blood volume. Less blood may reach the placenta, reducing oxygen and nutrient delivery to the fetus. They are generally avoided unless absolutely necessary. Allergies goes without a given. If you're allergic to sulfa, you are more likely going to be allergic to furosemide. So patients with severe sulfur allergy may have an increased risk for allergic reactions with furosemide. So remember, loop is in the loop of Henle. Check for electrolytes, especially potassium and magnesium. Check the blood pressures, daily weights, signs of dehydration, mental status. It's powerful. It's a powerful diuretic, but they require careful monitoring. So use with caution as well with patients with kidney disease, diabetes, gout, lupus. They can cause elevated blood sugars. As stated before, it could trigger gout. You already know hypokalemia, metabolic alkalosis, hypocalcemia, dehydration, and hypotension. If given by a rapid IV push, loop diuretics can cause ototoxicity, leading to ringing of the ears or hearing loss. So you have to push it slow, not too fast. Be mindful. Loop diuretics, such as furosemide, have several important drug interactions. They can increase the risk of kidney and hearing damage when combined with aminoglycoside antibiotics like gentamicin, because gentamicin by itself can cause hearing loss. So if you doing a double whammy with Lasix and gentamicin, just yeah, you already know the patient's going to start reporting ringing of the ears or chemotherapy drugs like cisplatin. Because loop diuretics cause potassium loss, they can increase the risk of digoxin toxicity. They can also increase lithium levels, leading to lithium toxicity. NSAIDs like ibuprofen reduce blood flow to the kidneys, making loop diuretics less effective at removing sodium and water. Why do these interactions happen? When it comes to aminoglycosides or cisplatin, both can damage the kidneys and ears. Loop diuretics also have the potential together. It makes it a higher risk for nephrotoxicity and ototoxicity. Anticoagulants like warfarin. Loop diuretics may enhance anticoagulant effects, increase bleeding risk. So you monitor the INR and for signs of bleeding. When it comes to NSAIDs like ibuprofen, naproxen, indomethacin, NSAIDs decrease prostaglandin production, reducing kidney blood flow. The diuretic cannot work as well, so less sodium and water are excreted. You already know if it's going to risk hypokalemia, if the patient's on digoxin, low potassium makes the heart more sensitive to digoxin. It increases the risk for digoxin toxicity. What is the signs of digoxin toxicity? Nausea, vomiting, yellow vision, dysrhythmia. Lithium, when sodium is lost from the body, the kidneys try to reabsorb the sodium. Lithium is reabsorbed along with the sodium. Lithium levels rise. It increases the risk of toxicity. What would be the signs for this patient? Tremors, confusion, seizures. Think of the five major interactions with loop diuretics. Aminoglycosides with cisplatin increases kidney and hearing toxicity. Anticoagulants increase bleeding risk. NSAIDs decrease diuretic effects. Digoxin toxicity because it drops the potassium. Lithium because it elevates the lithium toxicity. You already know. I don't know why I keep telling you this, but monitor potassium, kidney function, hearing changes, digoxin levels, lithium levels, and signs for bleeding. Furosemide is our prototype drug. It works in the ascending loop of Henle, where it blocks sodium and chloride reabsorption. As sodium stays in the urine, water follows, causing rapid fluid loss. It commonly used to treat heart failure, pulmonary edema, hypertension, and regular lower extremity edema. When given IV push, it starts working in about 5 minutes, making it ideal for emergencies. Nurses should monitor for dehydration, low blood pressure, potassium, um, electrolyte imbalances, autotoxicity, especially with high doses of given through the IV. And always remember with these diuretics, check for orthostatic hypotension. When caring for patients with diuretics, our goal is to remove excess fluid safely while preventing complications. Daily weights, same scale, same time, same clothes, because weight changes are the best indicator for fluid balance. Give the medication early in the morning with food to reduce stomach upset and prevent nighttime urination. Monitor blood pressure, potassium levels, kidney function. INOs, also known as intake and output. Teach the patient to change positions slowly to prevent orthostatic hypotension. Avoid excess salts, report swelling or sudden weight changes, and keep all medications, including over-the-counter drugs, updated with their healthcare provider. Daily weights, take it in the morning, check potassium, prevent falls, limit sodium intake, report weight gain of 2 to 3 pounds in 24 hours or 5 pounds in a week, increased swelling or shortness of breath, complete medication reconciliation, including over-the-counter and herbal meds, because we know that some of these medications are not reported by our patients. So therapeutic communication will let us know what they're really taking. Carbonic anhydrase inhibitors such as acetazolamide. Anything with amide is with this carbonic anhydrase inhibitor class. They're mild diuretics. They work in the proximal convoluted tubule, which is the first part of the nephron after filtration. They block the enzyme carbonic anhydrase, preventing the kidneys from reabsorbing bicarbs and sodium. Because water follows sodium, more sodium, bicarbs, and water are excreted in the urine, causing a mild diuresis. They are not strong enough to treat severe edema alone, so they are usually given with other diuretics or to decrease aqueous human production in glaucoma, lowering intraocular pressure. So once you hear it's getting rid of bicarbs, what do you think will happen with your fluid and electrolytes? Yes, your patient will become more acidic. Because patients lose the bicarbs, these drugs can cause metabolic acidosis, which is a key adverse effect to remember. So with this medication, it's widely distributed throughout the body and it's eliminated unchanged in the kidneys and the urine. Because they depend on healthy kidneys and excretion, kidney function should be monitored. They should not be used in patients with allergies to sulfonamides or non-congestive angle closure glaucoma. or during pregnancy because they have been associated with fetal anomalies. So this one definitely cannot be given with pregnancy. Allergic to sulfa, can't take it. Don't give it to angular closure glaucoma, pregnancy. Just remember these are very important. Make sure you understand that it's excreted from the urine. So if it's excreted from the urine, you have to check BUN, creatinine, the renal functions. So I can't say the name too well. That's why. Carbonic anhydrase inhibitors should be used with caution with patients who lose bicarbs, sodium, potassium, and water because it could cause F&E imbalances and metabolic acidosis. They should be avoided in patients with kidney and liver disease because the drug may accumulate and worsen complications. They could also worsen adrenocortical insufficiency, respiratory acidosis, and COPD because these patients already have difficulty maintaining their body's acid-base balance. Nurses should closely monitor electrolytes, kidney function, hydration status, and acid-base balance. So which type of fluid and electrolyte imbalance would you think this would happen? Metabolic acidosis. Why? Because it decreases bicarbs. It gets rid of the bicarbs in the body, which remains the body to be acidotic. As I said before, so you might also see paresthesia, numbness and tingling, confusion, drowsiness. Acid builds up, causing metabolic acidosis. And some of the NSAIDs like aspirin, you have to be mindful of that. Avoid combining these drugs because it could worsen the metabolic acidosis. Our prototype drug, it affects the proximal convoluted tubule. Major indication is for glaucoma, so it could decrease the amount of fluid, aqueous humor production, so the fluid in the eye. It also is used for acute mountain sickness. Key adverse effect is metabolic acidosis from bicarb loss. Monitor electrolytes like sodium and potassium. Check your kidney functions like the BUN and creatinine. Where can you find the BUN and creatinine? In your CMP or BMP. Check your patient's hydration status and fluid and electrolytes, acid base. Once you hear the word potassium sparing, you should understand that all the other diuretics was getting rid of the potassium. So if you hear potassium sparing diuretic, you know that this means it's holding on to the potassium. Potassium sparing diuretics are the weakest diuretics, but they have one very important advantage. They prevent the potassium loss. Most work by blocking aldosterone in the late distal tubule and collecting duct. Aldosterone normally tells the kidneys to keep the sodium and water, but get rid of potassium. When we block aldosterone, sodium and water leave the urine, but potassium stays in the bloodstream. These drugs are often combined with loop and thiazide diuretics to prevent hypokalemia. Common medications include spironolactone, epinephrine, amiloride, and trimeteride. So for the sake of your brain, just focus on spironolactone and epinephrine. So an easy way to remember, it saves salt, loses potassium. That is the function for aldosterone. So potassium sparing diuretics do the opposite. They lose sodium and water, keep the potassium. So watch out for what? Do you think you're going to look out for hypokalemia or hyperkalemia? Correct. Hyperkalemia because we're sparing the potassium. So especially with ACE inhibitors, ARBs, and potassium supplements. Even though you're going to be watching the potassium levels and kidney function. Teach the patient to avoid potassium containing salt substitutes, and excessive high potassium foods. Looking at the nephron, potassium-sparing diuretics work at the very end. Potassium at the very end right here. And it blocks potassium secretion, therefore retaining potassium. These drugs are usually combined with thiazide diuretics to prevent hypokalemia and are especially beneficial in heart failure. And they are also the drug of choice for hyperaldosteronism because there's too much aldosterone. This is an aldosterone antagonist, which is going to interact with that aldosterone to prevent sodium reabsorption. So it's at the end of the nephron. You lose sodium and water. You save the potassium. It blocks aldosterone and it improves the survival of heart failure patients. Always monitor for potassium levels because these drugs can cause hyperkalemia, especially with patients taking ACE inhibitors, ARBs, or potassium supplements. Spironolactone are well absorbed throughout the body, is metabolized in the liver, and primarily excreted in the urine. They cross the placenta and enter breast milk, which is cautious in those patients. If the patient has hyperkalemia, we're not giving this medication. If the patient has severe kidney disease, we're not giving this medication because they're not able to get rid of the potassium. If they're not able to urinate, that's another problem because increased potassium levels require functioning kidneys to be effective. Check for kidney function, check for EKG changes to prevent life-threatening hyperkalemia. If your patient has hyperkalemia, what would you see? What would be an EKG change? Correct. Peak T waves. Potassium-sparing diuretics should be used with caution during pregnancy and require close monitoring because most serious adverse effects is hyperkalemia. I'm tired of saying this. If you don't know this by now, I don't know what to tell you. Just joking. Just remember that also with this medication, it can cause some hormonal changes in men, breast tenderness, irregular menstrual periods in females, decreased libido, and voice changes in the female. Gynecomastia in men. Gynecomastia means breast changes, increase in breast size. So spironolactone can cause gynecomastia and decreased libido in men. Women may experience breast tenderness, irregular menses, and voice changes, deep voice. Here is our prototype, aldactone, also known as spironolactone. It is in the distal tubule collecting duct. It blocks aldosterone, so you can lose sodium and water, but save the potassium. It's used for heart failure, hypertension, edema, cirrhosis, hyperaldosteronism. Major effect is hyperkalemia. If there's a problem with hyperkalemia, there's EKG changes, it could cause a problem with the heart. The unique side effect that you need to understand, it causes gynecomastia, decreased libido, breast tenderness, irregular menses, and voice changes. Monitor potassium, kidney function, blood pressure, daily weights. Avoid potassium supplements and salt substitutes unless prescribed. So here's my question for you. True or false? The loop diuretic caused the body to excrete a copious amount of potassium-rich urine. False. Loop diuretics block the chloride pump in the ascending loop of Henle, where 30% of the filtered sodium is normally reabsorbed. The action decreases the reabsorption of sodium and chloride, not potassium. The loop diuretics have a similar effect in the descending loop, of Henle and is distal. All right, so just remember sodium rich or chloride rich, not potassium for loop diuretics. Osmotic diuretics. Our prototype will be mannitol. It's the only one, actually. So looking at the diagram, it works at the beginning of the nephron, around the glomerulus. This is the glomerulus and proximal tubule, right? So unlike other diuretics, it does not block sodium transporters. Instead, mannitol is like a large sugar molecule that stays inside the renal tubule and pulls water into the urine by osmosis. This produces a large amount of urine while causing relatively little sodium loss. Mannitol is mainly used in emergencies to reduce intracranial pressure, lower intraocular pressure in glaucoma, and help maintain urine flow in acute kidney injury. However, so when you look at this, it does not block sodium. It causes large amount of urine excretion, but remember, mannitol is like a magnet for water. It pulls water into the renal tubules without directly blocking sodium transport. Why do we use this for? It increases intracranial for increased intracranial pressure. We want to decrease intracranial pressure. We want to decrease cerebral edema. We give it for acute glaucoma and to maintain urine output in acute kidney injury patients. So if you already know intracranial pressure, where do you think that this is happening? Correct, the brain. So what do you think you as nurses will have to check? Neural status, as well as urine output, because that's the only way you're going to know that this is getting effective when your patient starts diuresing or urinating more. Check serum osmolality. Check your electrolytes. Check for signs for pulmonary edema because the drug initially pulls fluid from the tissues into the bloodstream before it is excreted. Osmotic diuretics, such as mannitol, work differently from other diuretics because they do not block what? Sodium. So, who would be contraindicated? People who cannot urinate. Heart failure, because heart failure patients already have some type of congestion. Mannitol first pulls fluid from the tissues into the bloodstream before it's excreted. This temporarily increases the blood volume, which can worsen heart failure and cause pulmonary edema. If the patient is bleeding in the brain, intracranial bleeding, except during neurosurgery, increased blood flow may worsen the bleeding. Severe dehydration, mannitol removes even more water, so making dehydration worse. Remember these things and you will be prudent as a nurse. So these are our cautions. Pregnancy, fluid shifts may cause heart failure and pulmonary edema. Check for hypotension and dehydration. Monitor neural status. Check for nausea, vomiting, lightheadedness, headaches, infusion site reactions. That's one of the effects as well. Here is our prototype. The route is IV only. It's used for increased intracranial pressure, cerebral edema, also used for acute glaucoma because it reduces intraocular pressure. It pulls the water from the renal tubule by osmosis. Major risk is pulmonary edema, dehydration, hypotension, electrolyte imbalances. How do carbonic anhydrase inhibitors work? They slow down the reabsorption of sodium. They speed up the creation of sodium bicarbs. They balance acidic and alkalinic solute in the urine, or they slow down the movement of hydrogen ions. Here you got it. They slow down the movement of hydrogen ions because diuretics that block the effects of carbon anhydrase slow down the movement of hydrogen ions. As a result, more sodium and bicarbs are lost in the urine. Here is like a brief compare and contrast chart. Hopefully this helps. As nurses, remember, always assess daily weights, intake and output, blood pressure, orthostatic vital signs, electrolytes, especially your potassium, kidney function, especially your BUN, creatinine, GFR, lung sounds for excess fluid in the lungs, where you will hear crackles, check for edema, check for skin turgor with their hydration status. Teach the patients to take diuretics early in the morning, rise slowly, limit sodium intake, not restrict sodium intake, but limit. Avoid dehydration. Monitor daily weights. Same scale, same clothes, same time. Report rapid weight gain, swelling, dizziness, and muscle weakness. Avoid over-the-counter medications and supplements without consulting the provider. Keep all follow-up lab appointments because we need to check the electrolytes. We need to check the kidney functions. So by this, you should be able to tell me which part of the nephron each diuretic works on, understand which prototype drug for each class, the mechanism of action, major therapeutic effects, major adverse reactions, electrolyte abnormalities. What are your nursing interventions? How would you educate your patients? What are contraindications? And some of the drug interactions that are important for you to know. So each diuretic works at a different location in the nephron, which determines how much fluid is removed, which electrolytes are more affected, and the clinical conditions it treats. Safe nursing care depends on recognizing each drug's mechanism, monitoring for adverse effects, preventing complications, and educating the patients to promote effective therapy. Thank you.